So I'm here today with Lesley Regan, who is only the second president in history of RCOG, the Royal College of Obstetricians and Gynaecologists. And Lesley was here today to talk about gender equity and the Sustainable Development Goal number 5, is that right?
Number 5.
Yes.
SDG 5.
Yeah, so could you give me, the very, snapshot summary of your discussion this morning?
Well, SDG 5 is one of 17 Sustainable Development Goals that we embarked on as a world, the United Nations. And between the 1st of January 2016 and the 31st of December 2030, we've got to achieve SDG 5, which is to empower all girls and women and ensure gender equity. And it's an enormous task. But I believe, as an obstetrician and gynaecologist by training, it's absolutely fundamental to improving women's healthcare, because we know that in societies where women's health is prioritised, that every aspect of that societal function is improved.
So you presented particularly on maternal mortality this morning. Could you talk us through that?
Well, I've chosen maternal mortality to illustrate it because I think everybody can understand that when a mother dies, it's a tragedy. It's often a tragedy for her family. And if your mother was to die delivering your younger sister or brother, the chances of you getting to school, being vaccinated, having clean water, being educated properly, start to fall dramatically. So I think it's a metric that people really can understand and equate to and can think, oh, what would have that happened to me? And the point I was trying to make is that the top 5 causes of maternal mortality across the globe, 4 of those top causes account for about 90% of the deaths. And for each of those causes, we do have cheap, heat-tolerant interventions or drugs that could actually change those statistics. So my argument is that so many of these deaths are preventable if the society in which that woman or that girl is living actually prioritises her health. And what we know is that this year, about 300,000 girls and women will die for the simple reason that they got pregnant. And the vast majority of those deaths will be to women who have no control over whether they get pregnant or not. They have no access to contraception. It means that they can't make decisions about if and when and with whom and how many times they become pregnant. They are impregnated. And of those 300,000 deaths that are likely to occur in this year, in 2019, 1 in 4 of those deaths will be an adolescent girl.
Shocking.
And I find that really shocking. So the example I was using was that if you look at the global map, I think most people in this audience who've trained in the field of obstetrics and gynecology understand that the real burden of disease is in sub-Saharan Africa. So I was showing a map where red is sub-Saharan Africa, and there's parts of Asia and there's parts of South America which also have poor mortality ratios. But when you compare that to the risk of dying in the developed world, which is about 1 in 7,000 something, and you start to go down Africa, when you get to Chad, there's a 1 in 8 chance of that girl or woman dying because she became pregnant, which means that in Chad, if you're a girl, you've got more chance of dying because somebody got you pregnant than you have of finishing your secondary school. And I think in the 21st century, that's a pretty shocking statistic.
So you talked about political will and, the politics is the key to unlocking all of this.
Yes, so when I was at medical school, which is a very long time ago now, I had people who talked a bit about global health, and we were taught in a certain way, to improve health globally and in the UK, because I've always practiced, predominantly in the UK. We all talked about, what we had to do, and that in the global south, there was the reasons why women died or had bad outcomes was because there was a delay in reaching care, a delay in accessing care. It was called the 3 delays model. And as I did more and more work and tried to influence things more globally and again nationally in the UK, I started to realise that you can have the most fantastic training, you can have the most wonderful drugs, you can have an NHS which is free at the point of delivery, but if you don't have political will to make things happen, you can never make a sustainable difference. And if you don't have literacy, you can't make sustainable difference. So if your sister, my daughters, if I can empower them with literacy or with information to know how to help themselves, they've got a much better chance of surviving, whether they live in London, UK, or whether they live in Chad. So I think it's the literacy and the political will, and for those of us who've not lived or had to exist in a world where women are not even second-rate but third-rate citizens, understanding what that girl or woman may be exposed to in terms of her gender status is really important. And it really colours how you can run improvement programmes, because if you can't access women because they're illiterate or they've got poor literacy, and you don't have a political system who understand the importance of championing women to improve the whole of society, then you could make a little bit of a difference. But it's just like that proverbial colonial. You know, you helicopter in, you do a few good things to a few people, you push off, and it all goes back to where it was before. You've got to have political will.
You also talked about politicians valuing the lives of these women.
Yeah. And I think that now more and more our politicians are realising that it's not just health that empowers women and improves society. I gave you the example of, you know, if your mother dies, then a whole family suffers. But it's also to do with their socio-economic empowerment. So when you've got women in microeconomies, you find that they do incredibly well. And so they'll save up the money for their kids to do this, that and the other. So it's in every aspect of life. The more women you have involved in leadership roles, the more robust that society is. And I think sometimes it's a bit uncomfortable for the other gender to cope with that.
There were some discussions about that here this morning, the launch of a gender equity report. You spoke about the elephants in the room being contraception and abortion. Perhaps there's another elephant in the room, which is climate change hasn't really come into the discussions here, and you didn't mention it, but arguably it's very important to achieving the Sustainable Development Goals. What are your thoughts on that, especially for women?
Yes, and I think it is very important, and I had quite a lot to get over this morning, so I didn't focus on that because I didn't want them to distract them from my message, which from in an international meeting which is focusing on obstetrics and gynecology, for one of their guest speakers to say, actually, this is all a waste of time unless you champion abortion care and contraception, it can get a mixed response, that message. But it's not that I don't think the other things are important, but what I was trying to encourage the audience to think about was that you can't go on firefighting in the delivery unit and the birthing unit, or the birthing hut even, or even beside the road. That doesn't do anything in a sustained way. If you really want to change maternal mortality and morbidity, you've got to get back upstream, and you've got to get women into a position where they are empowered to take control of if, when and how many times they get pregnant. Now, when you talk about gender equality or gender equity by 2030, I think a lot of people go, really? And it's scary. And the same way I think when people talk about climate change, what? And there's that wonderful actress who made that wonderful comment, I can't remember her name now, saying, and I kept looking around and wondering why someone didn't do something about it. And it could be maternal mortality or it could be climate change. And then she said, and then I realised that I was one of those somebodies and that I have to do something. So I was trying to say to this audience today that whether we were talking about the importance of contraception and abortion care in underpinning women's health and underpinning society, so too does climate change and what we've effectively dumped on the next generation, my children and their children. And then I think so many times we are paralysed by these big discussions because you think, oh, what can I do about it? I'm too little to do anything on my own. So my message today, hopefully to that audience, was if everyone in this room did one thing this week to improve gender equity, we would really change the world.
Yeah, you spoke also about the power of language. Could you explain, some of your experiences with that? You particularly spoke about it in the context of abortion, but yeah.
Well, I've been very struck by how important language is. I was sharing the fact that there are quite vocal lobbies, both in the UK, the US, and around the world, who are anti-choice. And there is another name for that, which starts pro, But you notice I don't finish it because I no longer use that word. I only refer to people as being anti-choice. Because I signed a Hippocratic oath. And so why wouldn't I be pro-choice at all times? And I think language is really important, that if something is very evocative or very damaging, I think I've made a conscious decision that I'm going to not use certain words. And similarly, I was explaining that in the UK we have an organisation called NICE, the National Institute for Clinical Excellence, who are the gold standard for medical guidelines. And one of my battles, successful battles, has been to persuade NICE to co-badge a guideline on abortion care. But we have deliberately called it abortion care. In the past, guidelines such as those, for example, the one by the WHO, by the Royal College of ONG, by the American College, have always been referred to as termination of pregnancy. And I think just by using the word abortion care, you immediately feel softer and warmer towards it, because you are painting that abortion care provider not as a terminationer, but as a care provider. I think it's just one word, or rather one way in which we can move towards more empathetic understanding of what the core problems are in women's health. And whatever your political or your ethical or your societal or your moral or your religious viewpoint, if you don't have safe, compassionate abortion care in your society, then girls and women will die.
There's a big discussion going on here at the moment, and I guess more broadly, about healthcare providers as advocates, being beyond the clinic, advocating for their patients about social determinants of health. The president of this college spoke about it this morning here. What's your view on, healthcare professionals as advocates? Is it appropriate? Isn't it appropriate? People have...
I think it's absolutely crucial. And when I started as president of the RCOG, I said, my goal or my vision is to make this the go-to place, the place where the politicians and the policymakers and the public, our patients and the professionals go to get high quality care. And that we've got to advocate for women and women's health, because in so many parts of my own country and around the world, some of the most disadvantaged girls and women have got no voice of their own. And I think as an obstetrician and gynaecologist, I have had the privilege, ever since I qualified, of looking after girls and women throughout their life course. There is no other specialty that does that. So we look after from cradle to grave, literally. And there are so many occasions when you and I will need to see a gynaecologist, not necessarily when we're ill, but we're just doing maintenance things. We need to have a cervical smear done, or we need some contraception, or we need to have our baby delivered, or we need our menopause treated. I'm very hot on the menopause as a menopausal woman. I think it's really important that we ensure that women post-reproductively have a really good quality of life. You see, I'm the first generation of women who are going to live for longer post-reproductive than I lived in my reproductive years. Now, that wasn't the case for my mother. And so I think it's really important, and I think O&G professionals have this most unique position where if they harness their expertise and their advocacy skills, they can make a real impact on girls and women throughout this whole life course.
And you are interested in some of your highlights from this week. What are some things you've been interested in reflecting on here or have learned?
Well, I've learned a lot about my colleagues here. I thought that I didn't realise that there were so many obstacles to healthcare with the payment system. I thought it was all actually sorted out. I've just been in a session where I was hearing about the problems in accessing misoprostol for abortion care. So in my talk earlier, I was congratulating all my Australian colleagues on the fantastic way they've got abortion decriminalised. But of course, what I hadn't really appreciated until I started talking to them as individuals and attending some of the sessions is that you've got a fantastic legal framework, but that doesn't necessarily mean you've got capacity. And that there's an enormous amount that has to be done to change hearts and minds, to get people to realise how they can capitalise on that legal framework to really improve care. So it's coming back to my political will, but it's not enough to change the law, and it's not enough to have political will. We've got to get the clinicians to understand what their role is too, and to buy into it. And I think it comes back to a point I was making during my talk when I was working in the Western Cape of South Africa and in Tanzania, where I realised when I analysed the outcome of the postpartum IUD and safe abortion services that I was helping to set up, that actually it wasn't the training that mattered, and it wasn't the guidelines really, it wasn't even the raw materials, it was changing hearts and minds. And I had to get the people, the healthcare professionals, some of whom had very few qualifications, not just to do the job, but to feel really proud of it, to be an advocate for everybody having access to these programs. So I think we have, in our specialty, we have the most extraordinary opportunities to advocate for girls and women, for men too, but I'm not possibly the best person to deal with men's health.
You shared the Ryan Fellowship you discussed. Could you talk a little bit about that? It sounds very interesting, and everyone in the room was very sort of interested in, could we do something like that here?
So the Ryan Fellowship was set up by a wonderful husband and wife couple called Utalandi and Phil Darney from the University of San Francisco in California. And the Ryan Fellowship training program is in reproductive medicine and reproductive health care. And it's highly sought after. It's a great badge of esteem. And of course it deals with all sorts of branches of reproductive medicine and contraception and etc. and also abortion care. Now you know that the political landscape in the US is rocky at the moment. Not in California, I might add, and not in New York State, but in many other countries in the middle, and certainly in the South, abortion is being banned. The law hasn't changed, but individual states have changed the interpretation of the law. The Ryan Fellowship program, if you were to sign on as a trainee, you would have to sign a contract that said that you would participate, even if you described yourself as a conscientious objector, which in this particular training program, they don't use those words, they use partial participant. But you would not be accepted to go on that program unless you agreed that you would sit in with me when I was talking to a woman who was requesting an abortion, so that you at least were exposed to understanding what her reasons were, and possibly having a vignette or a snapshot of quite how desperate she is and what a terrible situation she finds herself in. I've never met a woman who has an abortion just like that and doesn't really think about it. Never. And the point I was trying to make was that by insisting that everybody who wants to become part of this prestigious training program has to at least be an observer, what the organisers of the training fellowship have found is that over 90% of those individuals who start off as partial participants or conscientious objectors become full participants when they've been exposed to the reasons and the social injustices and the horrible inequalities that those women who are coming to them asking for an abortion have been subjected to. And I think that's a very powerful argument.
And for you, as only the second president of ARCOG, and there's a similar picture here, we've only had 2 female presidents ever of the colleges of ONG here. What are some of the things that are standing in the way? Why people are amazed, I think, that a women's health specialty can still be so dominated by men, you know, in Australia and in your own country as well. What are the reasons?
Well, I think medicine is a very hierarchical system, and it takes a lot of time to change that hierarchy. And I think sometimes women are a bit daunting, or we're a bit scary. I'm often asked by younger female trainees or younger female consultant colleagues, you know, do you think then the women can have everything? And usually my answer is, and it took me a long time to decide on my real answer, I think women can have everything. They can have a career. They can be an academic as well as a respected clinician. They can have children. They can have outside hobbies. But I think what women have to understand is that they can't necessarily have it all at the same time. And therein is a thing I think we have to persuade the young women who are coming through our specialty, and remember that the vast majority of our trainees now are women. We have to persuade them to stand up and be counted and to go for those leadership positions. Because I'm an incurable optimist, so I think if you recruit 70–80% of all your trainees as women, there has to come a time when the women will end up being in the leadership positions too. But in the next 10 years or so, I think we've got to give them special encouragement And we've got to also make sure that we don't have any of these, we don't have situations in which those women who've made it don't make it easy for the women coming on behind. You know, this tall poppy syndrome, or you know, the women who go through the glass ceiling and then whisk away the escalator or the staircase. We've got no time for that anymore. We've got to make sure that women are supporting other women, celebrating them, helping them to understand what they can do to get into those leadership positions. And once again, I think this specialty of O&G has got the most amazing opportunities to do that. And if we can't do it in our specialty, then which specialty can?
And the theme of the conference, Stop, Start, Continue. What were your Stop, Start, Continues from this morning?
Well, mine were quite easy. Mine was stop firefighting in these delivery units and birthing huts. And if you really want to change maternal mortality and women's health in general, you've got to go back upstream and provide women with the knowledge and the resources to decide if, when, how many times they get pregnant. That'll help with the leadership bits as well. And the start was that we've got to start talking to everybody about the importance of political will if we want to change the landscape in a sustainable way. And I used an example of continuing of we mustn't stop halfway, because as I was mentioning earlier, I think so many times if you talk about climate change or you're talking about sustainable development goals, and the one that I wanted to major on today, which was achieving gender equity by 2030, it's just too easy to think it's too big, that what can I do, I'm only little me. And so I was showing them a United Nations film that was put together about how, giving them some real life examples, which I think everybody in the audience resonated with. Right, you wouldn't stop halfway going to the moon, Usain Bolt wouldn't stop halfway to the finishing line, Coldplay wouldn't stop halfway through the song. You've actually got to get to the end. And so hopefully I got a few people in that room to think, oh yes, this week, before the end of this week, I can do something to improve gender equity.
You're the incurable optimist. Do you think we're going to get there?
We are going to get there, yes. I am an optimist, yes. And I also think that opportunities don't make appointments. You just have to grab them every time you see them.
Very nice.